Expected value of artificial intelligence in gastrointestinal endoscopy, European Society of Gastrointestinal Endoscopy, ESGE, Position Statement. Introduction. Artificial intelligence, AI, represents a radical breakthrough in the performance of diagnostic endoscopy by assisting the endoscopist in well-defined narrow tasks, such as detection and characterization of GI neoplasia. This is based on real-time outputs from appropriately trained software, mainly based on deep learning architecture that is able to recognize different endoscopic patterns of GI diseases in real time. Because of the rapid completion and supply of AI systems by technology manufacturers, one may expect immediate implementation of AI by the endoscopy community before conclusive scientific evidence on its impact is available. However, AI benefits, as well as harms, can be predicted on the basis of the clinical relevance of the expected task and the preliminary evidence in artificial or clinical settings. In detail, the expected value of AI, that is, the value one can anticipate before well-designed clinical trials, depends on the clinical implications of pitfalls in endoscopic performance on the one hand, and the plausibility of AI's compensating for such pitfalls on the other. This expected value is also affected by the possible harms of AI, such as the consequences of false positive results or AI-related de-skilling of endoscopists. The value of AI is also affected by the training and level of expertise of the endoscopist, the prevalence and severity of a disease, and the interaction between AI and the human endoscopists. In addition, clear definition of reference standards is needed to in turn define the value of AI in the management of GI neoplasia. The expected value of AI-related tasks is most naturally assessed within the framework of the quality performance measures already defined by the European Society of Gastrointestinal Endoscopy, ESGE, for specific techniques. The main advantages are the availability of a clear definition and measurement method for each indicator, as well as a well-defined, clinically relevant cutoff where appropriate. This setting is also likely to facilitate a more transparent assessment of the benefits and harms of AI systems in clinical practice, preventing pointless duplication of performance measures. However, due to the novelty of AI, one may expect that at least some AI-related tasks are not covered by the available performance measures, prompting the definition of new AI-oriented performance measures. This may be considered to be an additional benefit of AI for the quality of diagnostic endoscopy. The aim of this ESGE position statement is to define the main outcomes of AI tasks in the setting of ESGE performance measures, anticipating minimum and desirable values that should be expected when implementing AI in practice. The general assumption is that AI implementation may standardize the quality metrics in community endoscopy, and thus clinical rather than technical validation is preferentially addressed. Similarly to the performance measures documents, the main focus of this position statement is the detection and characterization of GI neoplasia. Main recommendations. For acceptance of AI in assessment of completeness of upper GI endoscopy, the adequate level of mucosal inspection with AI should be comparable to that assessed by experienced endoscopists. For acceptance of AI in assessment of completeness of upper GI endoscopy, automated recognition and photo documentation of relevant anatomical landmarks should be obtained in 90% or more of the procedures. For acceptance of AI in the detection of Barrett's high-grade intraepithelial neoplasia or cancer, the AI-assisted detection rate for suspicious lesions for targeted biopsies should be comparable to that of experienced endoscopists with or without advanced imaging techniques. For acceptance of AI in the management of Barrett's neoplasia, AI-assisted selection of lesions amenable to endoscopic resection should be comparable to that of experienced endoscopists. For acceptance of AI in the diagnosis of gastric precancerous conditions, AI-assisted diagnosis of atrophy and intestinal metaplasia should be comparable to that provided by the established biopsy protocol, including the estimation of extent and consequent allocation to the correct endoscopic surveillance interval. For acceptance of artificial intelligence for automated lesion detection in small bowel capsule endoscopy, the performance of AI-assisted reading should be comparable to that of experienced endoscopists for lesion detection, without increasing but possibly reducing the reading time of the operator. For acceptance of AI in the detection of colorectal polyps, the AI-assisted adenoma detection rate should be comparable to that of experienced endoscopists. For acceptance of AI optical diagnosis of diminutive polyps 5 millimeters or smaller, AI-assisted characterization should match performance standards for implementing resect and discard and diagnose and leave strategies. For acceptance of AI in the management of polyps 6 millimeters or larger, AI-assisted characterization should be comparable to that of experienced endoscopists in selecting lesions amenable to endoscopic resection.